Welcome to the Provider's Report, where we delve into the world of value-based healthcare. Our mission is to empower healthcare providers with the knowledge and tools they need to deliver exceptional patient care. Each episode, we explore best practices, innovative strategies, and real-world examples of how to achieve the highest standards in patient communication and outcomes. Join us as we transform the future of healthcare, one conversation at a time.
Hey guys, we're back at it with Doctors Nick and Matt, chatting about all things direct primary care. Some of us may never have heard of such a thing. I know I was completely unfamiliar until recently. So we're going to dissect the ins and outs about how the system works, and maybe you'll even realize this might be a great fit for you. That's exactly what happened to the doctors we're talking to on today's episode. They discovered as they began to make their future plans post-residency that this style of practice really truly suited their future goals. The setup is simply just something that enables us to be more patient-centered and truly develop optimal relationships with our patients through direct primary care. So let's see what they have to say. Hey everyone, we are here tonight with Dr. Matt and Dr. Nick. Thank you guys so much for joining us today.
Thanks for having us.
Absolutely. So today I'm really excited to talk about this first topic. We're going to be talking about direct primary care, which is the entire center of what you guys do. And I'm hoping you're going to touch on this in a little bit, but basically you opened this incredible office here in Grand Rapids that has the direct primary care focus. And I love the fact that the center of your practice seems to be better patient care all of the time. So for some of our guests and listeners who have no idea what direct primary care is, can you go ahead and explain that a little bit more in detail for us?
Yeah, so it's almost easier to talk about the typical way that medicine is delivered and then kind of bounce off that. So typically medicine, medical care is delivered through an insurance-based practice, and you kind of go see your doctor, you wait long wait times, make it in to see your doctor for 10, 15 minutes at most. And then you have to follow up somewhere 3 to 6 months down the line. And it's not a very efficient system. It's also not a cost-effective system. So direct primary care was kind of born out of that back in the early 2000s. It's actually a type of care delivery that's like a membership model where you pay a monthly membership to see your doctor, and all primary care that can be done out of the office is encompassed within that membership fee. So different direct primary cares will structure that a little bit differently as far as what the cost is. Oftentimes there's a pediatric, middle age, and then adult, older adult fee. But anything that we can do physically in the office is typically encompassed in that membership fee. So that's going to include all office visits. So we don't have copays for any office visits. Any home visits that we may do are included in that as well. We have access to cash-based blood work. So we actually have a lab that's about a half mile down the road from us. So if someone wants to get their cholesterol checked, it's $4.95. If someone wants to get their thyroid checked, it's $5. So we have access to those, and our members get access to those prices as well. We have wholesale costs as far as medications go. So in the state of Michigan, it's actually pretty friendly to be able to dispense medicines out of the office. So these are generic things: blood pressure medicines, diabetes medicines, cholesterol medicines, anti-inflammatories, almost anything that you can get generic and we feel comfortable prescribing, we can dispense out of the office at wholesale price, which oftentimes is about 90% below what you can get even after your insurance covers what they're going to cover. So that's a nice aspect for our patients as well. And then also any sort of imaging tests. So that's going to be x-rays, CAT scans, MRIs, those sort of things we get for cash prices as well. So all that is kind of included in the membership at no extra cost. Besides just what the cash rate is for those services. When we do procedures in the office, procedures are included as part of the membership. So if you have a mole that looks a little bit funny, we can remove the mole at no extra cost, but we just have a fee associated with the pathology if we have to send it out and have it looked at, which is about $60, $65. So things tend to be really reasonable when you kind of take the middlemen out of healthcare, which in the grand scheme of things, middlemen is health insurance. Now, we never advocate to go without health insurance, but most of our patients are uninsured risk just by the nature of the practice. And there's, roughly 1 million people who are uninsured in West Michigan. There's a lot of people that need care. So direct primary care kind of targets people who are uninsured, also targets people with high deductible health plans, but also people who just want access. The access part of it is big for us because we have kind of a portal system that looks like text messaging that people can get access to us when they need us. Ideally not at 2 a.m., but some things pop up and people can text us with simple concerns, right? If you get poison ivy, why would you have to take work off, take a half day off, and come see us in the office 2 weeks from now to get something for the poison ivy? Just literally text us a picture and we'll take care of it right away. Healthcare can be very efficient that way. It doesn't have to be this draconian way of doing healthcare. So really direct primary care is a take on efficient, affordable and accessible healthcare is really our tagline.
I love it. I also love how it's still relatively new. I mean, on the newer side. Do you think that this is progressing more and more across the nation and becoming even more popular?
Yeah, definitely. It's been about 10, 12 years now since these started popping up. A little bit more since it became more of an organized coalition of people. There aren't really a link between any of us other than we're all doing a similar thing and we often communicate together. But, call it a decade and it's definitely growing. I forget the numbers, Matt may be able to help me here, but when we opened, there was a few hundred nationally, and within a year of us opening, it was over 1,300, I think.
Wow.
I haven't seen that number in the last year, but it's definitely continued to grow. We know there's other docs in the West Michigan area who are kind of eyeing us, and we hear from them because they think it's interesting. There's now, I think, 4 individual practices in the Grand Rapids area with a bigger group practice also there. So it's definitely growing, and nationwide it's definitely growing as well.
And really the idea of price transparency is a big thing. And people are getting fed up with surprise bills and excessive costs for things that really aren't that expensive. The cost versus the price is really one of the things we like to talk with people about. The cost of a CBC just to check your blood counts is $3.40 for us. But I just talked to someone today who, it was $130 for them after their insurance covered what they were going to cover. So, insurance isn't always going to be the best thing, especially for primary care. If you're having an emergency, sure, insurance is going to cover you and hopefully prevent you from having some bankruptcy associated with whatever emergency you're having. We know that's not really the case. But, from a primary care standpoint, insurance isn't always the best thing.
Right.
This is such an amazing way to lessen this global burden I think we're all feeling right now with healthcare, and especially with the trend of going a little more digital and doing a lot more telehealth this year. This is such a great way to set the stage, I think, for potentially the whole future of healthcare. Because I know one of the biggest complaints that I get from my patients about their primary care facilities or physicians, aside from, of course, not having enough time with them or having trouble getting in with them when they have something urgent, which you guys have already touched on. One of the biggest complaints is that they feel like sometimes their physicians are making decisions based on what their insurance will pay for and not actually what's best for them. And they don't always have access to that discussion or maybe that clinician's understanding of what's going on. And half the time they're like, hey, I would have just paid for that MRI out of pocket or whatever, and they don't always feel that their physician is practicing the way they would truly like to practice, which I think can be limiting for providers as well. So I'm curious to hear your thoughts on that and whether or not your clinical decision making is sometimes changed and maybe you feel more free now, or if you feel that other providers might be limited by
it definitely
their
depends.
relationship with insurance companies.
Met a guy fairly recently who had hurt his shoulder about a year ago, clearly tore his rotator cuff, and there was really no question about it. Saw the doctor, they agreed, yeah, you clearly tore your rotator cuff, we should get an MRI. Insurance said, nope, you gotta do physical therapy, which he started. COVID began, physical therapy stopped, and then I was seeing him, I think in December, and he's still having the exact same problem. He still clearly has a rotator cuff tear. And we're going to have to repeat the physical therapy in the insurance world, or for, I think it's about $400, he can get the MRI down, 2 hours away from where he lives. But he's like, wait, could I have done this in January? Yeah, you could have, but he didn't know. And the doctor he was with wasn't aware that there's a cash price on the other side of the state. I mean, I guess if you're not doing what we're doing, why would you be? But it is a big resource that people are unaware of. And to the same point, it definitely affects things. You get into terms of, even in our world, insulins, inhalers. These are things that don't have a cheap price. You can't get them wholesale. I mean, you can, it's still just hundreds of dollars. What do you do in those situations? When you're in the insurance system, it's super common. You say, oh, I want medicine X. And they say, no, you got to get medicine Y, or they have to fail A and B in order to get to X. And it's just all over the place. And you don't have that decision. And sometimes you can see where the insurance companies are coming from cost perspective. Doesn't mean it's best medicine, but you can kind of squint and see it. And other times it makes no sense. It's just completely arbitrary, whatever deal they've made. And it's very frustrating, especially if you're the patient who said, well, I was supposed to have this medicine here a week ago. Where is it? And at the doctor's office, they've sent in 3 different orders and each one's been denied. You can imagine what that's like for anyone.
Yeah.
It's something we talk about on here as well, is you can't have cookie cutter healthcare. You know, insurance companies are removed. They're not directly staring at the patient in front of them. So they don't always have a way to determine what's necessary for that patient. I know, touching on the MRI that you just spoke of, I can't even count how many times that I've had to go to bat, right, for my patients to get that MRI approved. When it's obvious to me with this patient in front of me, hey, this is exactly what they need to confirm what we suspect. And I actually remember my first year in practice, the doctor I was lucky to have a great mentor that year. And I remember listening to him with, I guess it was a nurse practitioner on the phone that he had to get the green light from the insurance company to approve this MRI. And so it was a peer-to-peer review, and they were just not budging on it. And I remember he specifically had to take it down and make it just very human to human. And he asked for their name, and he said, and they asked why. And he said, well, I need to tell the patient who's crying in the other room exactly why she can't have the test she needs. And the person on the other line said, all right, hang on a minute. And went and came back and was like, here's your authorization number. Sometimes you just have to remind people that this is a person in front of me. You know, we see it every day, but removing that extra step just sounds like it really benefits the patient and the provider in a way that we haven't been able to achieve, in the recent years until now. So I think my patients are going to be super excited to hear about this new direct primary care model. And I'm wondering, as it's becoming more popular, are they teaching this in medical schools, or is it something you just pursue once you get out?
Yeah, no, kind of. We've been invited to a couple of times to speak at various places.
Awesome.
Or we've met students along the way, and then they've spread the word, and we hear back from a different student or a resident, what are you doing? The answer is, as far as I know, it's not part of the core curriculum anywhere in particular. But I do know that the American Academy of Family Physicians is pushing it quite a bit. We just got another email about a resource packet about DPC. I mean, it's definitely an entity. It's not being hidden, but is it part of a core curriculum or anything? Not really. But then again, practice management in general has been kind of fallen to the side in a lot of ways.
Yeah.
That's where our professions can agree. And that's where we kind of go through some of the similar things. We don't learn a lot about practice management. We don't learn about all the options that are out there. And obviously our core curriculum should be clinical, but there's just so many things. And that's why, Dr. Annabelle and I really wanted to have this podcast, is because there's so many things missing that you either don't learn about until you've had 6 years of experience and just learn on your own over time. But how much more valuable would it be to be exposed to things early on? It makes a huge difference.
Well, there's so many things, so many things about starting your own practice that they're hard to even look up anymore. I mean, I remember talking to one of our good mentors. So Nick and I almost went into independent insurance practice, and then our tides completely turned in roughly about the middle of residency. But the guy that we had worked with, he's on the south side of Grand Rapids, and he remembers going through his practice management classes or courses in residency, and they teach you how many chairs to have in your office, how many exam rooms do you need, like how to come up with a business plan, like how to go through all those things. And I remember frantically Googling these things because we had no idea like how many chairs we need or where all these demographic studies, like where are we going to open this practice? There were just so many things that went into it that we just, we had a handful of lectures on practice management, but really those are all about coding for insurance. It has nothing to do with how to get your doors open and actually get patients into those doors. And it's just such a valuable thing to know. And our practice is completely different than insurance-based practice, but we still have some valuable lessons that we've learned in the past 2 years of being open, and we try to share those as much as we can with residents and medical students. We host them, we precept if we can, any number of things. So it's all about spreading the word, and we're try to be a somewhat tight-knit community, even though we're spread out all over the country. But it's all about trying to spread the word, and we're much more likely to help someone open a practice than franchise our own and, benefit off that. So we'd rather give free advice because that's what happened with us. Yeah.
One thing too, though, when you look at starting an insurance-based practice, we, like Matt said, we looked into it. We did, I'll tell you a demographic story later, but we did all this work, and we came up with a business plan. We did all of it, and we're looking at needing about $600,000 to go start a practice. You have to hire staff, you have to get an EMR, so many things. And then we found DPC, and it's not that. You need a space, or you could do house calls if you really wanted to and not worry about a space. There's definitely people out there doing that. You get an EMR system for way cheaper than anything that's available on the insurance side for the most part. That's it. What else do you need?
Wow.
You have a stethoscope, you have your table, do you have the things that you want? So much of starting a practice has to do with, you need staff to help you stay efficient in an inefficient system. That costs a lot. You need the ability you have to have billers, you have to hire a billing company, you have to do something, because you're going to have money sitting out there for 30, 60, 90 days waiting to come back from the various insurance companies. You have all these accounts receivable, you have so much going on, it's very complicated. And in DPC, it's very much the patient pays you, you take care of them.
End of story.
That's about it. Yeah.
So it sounds like because you don't have to worry about all of these other things being, as a business owner, you're able to devote even more time to just patient care.
Yeah, absolutely. I think our average visit time is still around 45 minutes. In part it's gone down because sometimes people just don't need that time. Now they know you and they're just popping in for a few minutes for whatever reason. But we have that time, and a lot of it comes from the efficiency side of it too. That person Matt mentioned with poison ivy isn't taking up a 20-minute slot or however much time you had allotted for it. You're just taking care of that quickly, and you focus on the people that need to be focused on. It's part of how we get people in same day, next day for most things. Don't get me wrong, if it's a Friday afternoon and it's a routine visit, we may try to get you to come in on Monday like anyone else. But if it's anything that needs to be seen, we'll do it.
Yeah, and DPC, we like to talk about touches, right? So we may only see, we're still building our practice. So if in a full practice, we may only see, between both of us, we may see 10 to 14 patients in the office. But really, we're probably going to be touching 40 to 50 a day, whether that's medication refills we send through the mail, text messages that we receive, forms that we fill out, any number of things. So those are all going to be in-person visits in an insurance-based system because it's fee for service. Now they're doing a little bit more with the telemedicine kind of stuff, but even those sort of things they want to see in person so they can bill to the fullest. From our perspective, if we're billing on a membership model, we don't necessarily, if we don't need to see you and we can take care of you just as well virtually or over the phone, heck, we might as well do that. Save all of us more time.
I say that all the time. If you don't want to be seen and we don't need to see you, then why are we going to waste your time?
It makes perfect sense. And, most of my training was at a VA hospital. And while I was there, I think because it was my first exposure to healthcare, I got kind of put into this bubble and I didn't realize the insurance-based model, because at the VA, you do exactly what the patient needs in that given moment, no ifs, ands, or buts. You don't think about what it's going to cost. You don't think about, anything regarding that. And I remember when I left the VA and started private practice, it was a complete 180. And all of a sudden I had to think in like a fake way of healthcare. I'll never forget when I realized that in the state of Michigan, we don't always get paid for the treatment of extremities. We're more of like a spine focused chiropractic profession. And not all insurance companies would cover that cost for that CPT code. And I remember that if somebody came in, like let's say a patient of mine, I had treated for low back pain for, X numbers of weeks or months, and all of a sudden they had a new complaint of a wrist injury. So when I evaluate their wrist and treat it, I actually can't bill for that extremity treatment unless I touch their spine. But here's the problem. What if that patient has no low back pain that day? What if they have no issues? What if they don't need treatment at all in their spine that day? I literally have had to sit people down, explain that weird insurance concept to them, and literally tell them I have to treat something on their spine in order for their insurance company to cover it. It made no sense at all.
No sense at all.
No
sense.
And there's just no way around it, unfortunately. So I know what some offices do. They have, some things that you bill cash, some things that you bill insurance. But again, it's messy. Like, I should be able to see a patient, give them what they need in that moment, and move on.
You would think so. It'd be the very it'd be the very reasonable thing to do, but it's frustrating. Multiple levels.
It is. So what are some examples of, things patients who have been so used to the insurance model, what are some things that they've, shared with you about how much more they appreciate your model?
I mean, it's more so I remember this distinctly. I had someone who was coming back from a test. So we have people that we consult with like all over the state. So, for imaging tests or EMGs, nerve conduction studies, that kind of stuff. So even like spinal injections, all sorts of odd things. So we had someone coming back from their injection on the east side of the state and called the office, and I answered right away. And she said she was talking to me on the phone, and the person that she was talking with, or the person that she was riding with in the car, was like, "Oh my God, how did you get a hold of your doctor so quickly?" And I was like, that's just kind of funny. I just started laughing about it. She's like, "Oh, this is just normal for me now." And people are so shocked when you actually get a hold of the doctor, provider, whoever you need to get a hold of, because typically there's like walls, in the phone tree where you just can't get a hold of the doctor at all. So a lot of people are very happy to just be able to have direct access and get things answered quickly. I mean, in the typical world, you may call and leave a message and not get a response for 4 to 7 days, especially with lab results, with all that sort of stuff. So our patients are very happy as far as if you have a quick question, boom, get it done. There's not necessarily waiting. One of the beauties of direct primary care is that you have easy access to us. And one of the things that can be frustrating is that patients have easy access to us. So it goes both ways. But for the most part, things have been awesome.
That's great.
It's so amazing. I feel like this solves so many problems that are in our current healthcare system. So I'm so excited to see this expand, and I already see this happening here where I practice in Florida. We even have a chiropractor here in town who's doing direct primary care for chiropractic and working with a direct primary care physician practice of MDs. It's really amazing to see this kind of collaboration. So I don't know, we're kind of like ready to sign up tomorrow. So for anyone listening who, maybe might be a young medical student, maybe some of the new docs that you work with, for anyone listening to the podcast who wants to make that switch and think about direct primary care for themselves and their practice, what advice would you give them? Where would you tell them to start?
One of the things the first thing I would say is there's a great website out there called DPCfrontier.com. It has pretty much everything you'll need to know about direct primary care as far as what laws you need to be aware of and what exactly it means. The guy who runs the website is actually a direct primary care physician. I can't remember exactly what state he's in, but he's like a prison doc. But he also happens to be an attorney.
Wow.
So he does. He's one of the guys that does a ton of literature review and all the law stuff. I mean, he doesn't give people specific advice, but he interprets things to the best of his ability and puts his interpretations out there. And then, we at least have something to go off of. But DPCfrontier.com is a great site. And honestly, what I would do if you're looking to, see if this is right for you is literally reach out to any direct primary care that's by you. And I can almost guarantee you they'd be willing to talk with you for however long they need to talk to you. Nick and I, we offer free consults for patients, not a consult, but at least a free meet and greet just to see if we're a good fit for you. We do that for not only patients, but even medical students. If someone wants to sit and grab coffee, this is pre-pandemic, but if someone wants to sit and grab coffee or, we're in Grand Rapids, Beer City, so we go out and grab a beer, whatever, and just sit and talk with people about direct primary care and what we do. And, we're more than happy to do that just to spread the word. So reach out to any DPC that's close by you, and I'm sure they'd be happy to chat.
Yeah, and just to prove the point, when we were senior residents, our director came to me and said, "Hey, we have these away weeks do you want some of them to go do exactly what Matt just described? And I thought, well, that sounds great. Yeah, why not? And I emailed Josh Umber of Atlas MD in Wichita, who's kind of one of the rock stars in our community. And I didn't know that at the time. I just happened to know he existed. And said, hey, can I come hang out with you for a month? He goes, yeah, for sure. You might just want to do a week. It might get boring, but yeah, come on out. And he gave me the advice of spend a week with me and then find some other DPC docs and spend a week with each of them. So I did, and spent 3 weeks. And I only emailed 3 people because they each got back to me and said, yeah, when do you want to come? Anytime, no problem. It really is a very open community. When Matt and I are trying to figure out what should our patient contract look like, what does this mean? It's going to be different than if you're signing an insurance one. And we sent out some emails, and literally every single person that had heard from us sent us not just their contract, but like every document you can think of for us to steal from. And again, it's just a very different environment. We're not competing with each other. I remember sitting in Josh's office, and this is the demographic story, actually. I'll tell that one first, where I was thinking, we need to repeat these demographic studies. Like we had looked at the populations of each area surrounding Grand Rapids. We drove around and found every primary care office and marked it on a map, so we knew exactly where can we get a hole that we get 6,000 patients for us to share. And he's asking me these questions about that. And he goes, okay, all right, yeah. How many people in West Michigan? I already Googled it. It's 1.2 million. How many patients do you guys need between the two of you? About 1,200, maybe less. He goes, right. What percentage is that? Doesn't matter. There's plenty of people there to share. And that was it. We ended up opening, although I don't think we realized it when we picked the location, but just a couple of miles from one of the other DPC offices. And it's not been a spot of contention as far as we know. We've still shared, we sent our patients we can't see. We've done all sorts of things because it's just collaborative. The more DPC, and really we keep using the word DPC, but a lot of people are using the term free market medicine now, because it's not just primary care doctors or specialists that are doing this. There's other people. It may have kind of fit with what we were starting, and that's what we named our practice was after that. But there's more going on here. But the more people that are out here doing free market medicine, the more it kind of spreads it. Oh, there's someone else doing this. Oh, there's someone else doing this. Oh yeah, my friend sees that kind of doctor too. And it becomes more of a geographic, all right, who's closest to me, or who do I mesh best with, as opposed to, picking your favorite healthcare system or something like you're choosing a sports team and just sticking with it.
Absolutely. And I think it's a great testament to the fact that your community is that way because of what you guys value. It's not competitive. There's no large competitive mindset. There's no, constant need for money. Your first and primary goal is patient care. And when you do that, you want to help other people achieve that same goal. You want other people to open up DPC offices. You want other people to also put patient care first, so we can have our little spot in helping the overall healthcare system be better. It's clear as day. So I thank you guys so much for what you do, and it's been great to have you on the show. And thanks for all of your great advice. We really appreciate it.
Well, thanks for having us.
Thanks for having us.
Awesome. Yeah,
absolutely. A new approach is always so exciting, and it's really awesome to see how much it's already grown in the United States. Something to also remember is that the style of direct primary care is also expanding to several specialties as well. So is something like this right for you? If not, it's pretty awesome to just understand it and know how it works, especially for your referral system. So let us know what you think. And remember, at BDP, our primary goal is better patient care through better knowledge and systems. Make sure you also check out episode 17 of BDP for more of Drs. Nick and Matt, where we chat about patient communication techniques and tips to make things extra smooth in our practices. Until next time.
Thank you for tuning in to the Providers Report. We hope you found today's episode valuable and inspiring. To stay updated with our latest episodes, subscribe to our podcast wherever you like to listen. For more resources and continuing education opportunities, visit our website. Together, we can make a difference in the lives of our patients and truly set a standard for value-based healthcare.